Good morning, everyone. It is Community Conversations. I'm Robin Shapiro. I'm the board chair of Health AdvocateX, and it's so great to be back with you for another wonderful community conversation. As a reminder, we will be recording this conversation. So if you don't want your video to be showing on the recording, which we make available to the public, please turn your camera off and please stay on mute until the Q&A portion of our conversation. I'm delighted to bring to you today, in addition to Dr. Dale Reisner, who is the medical director for Swedish Health Services, and she's also a board member for Health AdvocateX. We have a special guest, Josephine Young, and she is the medical director at Premera Blue Cross. And she works directly with large national and regional employers. She's a board member of the Foundation for Healthcare Quality. And what's really neat about her experience is that she has mental health experience. She's going to be talking to us about long COVID. She has a lot of other pieces of background that is really going to enrich our discussion today. One other thing that's really interesting about her is that Josephine and her husband started a parent-led support group 17 years ago for families affected by congenital heart defects. So she's a pediatrician and a mother of 4. So she's very busy, and we're grateful for her spending her time with us today. And she has a passion for helping patients, as you'll hear in a moment. But before we get to Josephine's presentation, I'd like to invite Dale Reisner to come on into the screen and give us an update on COVID-19. Dale?
Yeah, so hi, everybody. I know a lot of you guys are people that keep coming back for more. So I'll just be covering the data a little bit, and then one other piece that might be of interest regarding oral therapy for amelioration of positive cases. We want most of the conversation to be able to be led by Josephine with her experience. Our data as of today, globally, over 535 million cases. Again, we know our case ascertainment is incomplete, not only in the past, but even now, because we don't have everybody who's testing positive at home in our records necessarily. The death rate globally is over 6 million, 6.3 million. In the US, we have over 85 million cases and over 1 million deaths. And to put that over 85 million cases into perspective, that is, again, underreported, but approximately 26% of the entire US population has a known, reported, documented positive. So we know that that case rates are higher than they've ever been. Fortunately, the disease is milder, the death rates is way lower, the hospitalizations and ICU admissions are way lower. So I think that's all good news, even though if you look at a map of moderate to high transmission, the whole US lights up as bright orange or red. So there's little pockets where it's lower, but lots of transmission in the community. I did want to mention, and I've done this in the past, a little bit of perspective about race, ethnicity, and the impact of the disease for people of color. If you look at the case rates, I'm not going to give you numbers, I'm going to give you some perspective. American Indian or Alaska Native have 1.6 times the number of cases compared to Caucasian, okay? So 1.6 times greater cases, 3 times greater hospitalization, and over 2 times the death. If you look at Black or African American, the case rate is 1.1 times that of Caucasians. Hospitalizations, however, are more than 2-fold of those for Caucasians, and the death rate is 1.7 times Caucasian.
And Dale, Lisa Casaro would like to know what timeframes are being reported for cases and deaths.
This is a total assessment of
up to this week.
Up to the first week of June.
Yeah.
This week of June.
Great. Thank you.
Yeah. And the Hispanic population, 1.5 times the number of cases, 2.2 times the hospitalizations, and 1.8 times, almost 2 times the death rate. So that if you look at the Asian population, they have lower than Caucasian for everything. So 0.7, 0.8 for all the different things. They also have the highest vaccination rate in our country, if you're looking at US statistics. So it's important. I'm not talking about age related, because obviously age related makes a difference as well. And comorbidities such as diabetes, hypertension, high BMI, all of those things. I'm not going to talk about the pregnancy data. I do have it if people have questions. There's some interesting things coming out about what trimester people seem to be getting sicker in. We still continue with pregnancy to have lower vaccination rates than the general population for all races, including Caucasian. In the US, currently, about 83% of the entire population has had at least one of the vaccine doses. But when you look at fully vaccinated or boosted, the numbers fall off dramatically after that. So there's about total US population is over 332 million, just for perspective. About 200 million are fully vaccinated, not necessarily boosted, but at least with, either one shot for Johnson & Johnson or 2 for Moderna and Pfizer. And I think that's what's really making our outcomes look better, is that at least the bulk of 2/3 of the population basically has gone ahead with vaccination. Just we'll leave those statistics unless somebody has a question. I do want to talk just briefly about what do you do if you're vaccinated and you get a positive test or you're ill and you're in a high risk category. Any questions about the data? Okay, so there are multiple oral meds. I'm only going to talk about one of them, and that's the Pfizer oral antiviral specifically for COVID-19. It's called Paxlovid, and it is available for emergency use authorization per the CDC. So for people that are nervous about something that isn't fully vetted, they will not probably be interested in this. And there have been some pockets of supply, even if somebody is interested, where the supply is not available. It is for patients who are at least 12 years old, at least 88 pounds, and are high risk. So there could be a child with an autoimmune disease that's 14 years old that might be a candidate. Those who are over 65 for sure. And then some of the other things we've talked about, immunocompromised, high BMI, medical complications. So it's not available for everybody. It is a combination of 2 antiviral medications. And Merck has another one out that is called Lagevrio. Sorry, I'm not pronouncing it properly. It has not had this high success rate. It's about 30% effective in decreasing the complication rate and the severity of the illness, compared to Paxlovid, which was about 89% reduction. The one thing with Paxlovid, you must take it within 5 days of diagnosis, either the positive test or symptoms. And it is available if you're asymptomatic and high risk. Certainly available for the high risk population if you've got symptoms.
Is it available for anyone? Like how?
No, only for high risk.
Mm-hmm.
Okay, so if you're 45 years old and have no health issues, it would not be available to you, right? The you need to start it within 5 days. You take pills, 3 pills twice a day for 5 days. There has been some rebound effect. The percentage of rebound is hard to figure out yet because the use is not wide enough spread to know those numbers.
Can you describe what you mean by rebound effect?
Yeah. So the rebound effect is about 5 to 6 days after you take the medication, you may get symptoms back.
Oh.
It's not thought to be reinfection. It's the same infection. It's just that the disease was suppressed and your immune system is still saying, okay, well, that virus is still here, so I'm going to give you some symptoms. So that's really what that's all about. It has not been severe, but people need to know that that could happen. And again, we don't know the exact frequency. It started out with rare reports, and then as people are using it more often, we're seeing a little bit more of that.
Do we know how many people have gotten Paxlovid? And
I don't have any data on that. No, I don't. And you must get it with a doctor's prescription. You can't just walk into a pharmacy and get it. So you need to be evaluated, or if you have a primary care doc, you could potentially call that person and they would prescribe it. The other thing I know is that if you're traveling to New York City for a little weekend or a vacation or something like that, and you get a positive test or symptoms, your doctor in Washington State or Alabama is not going to be able to prescribe. It needs to be somebody local. So a walk-in clinic or someplace like that may be available to you, and you need to be high risk. Yeah. Myra, you got your hand up.
Yeah. One thing that is very important is you cannot take a statin if you're taking Paxlovid.
Yes.
I mean, so if you think you're exposed to COVID, you think there's a chance you're going to get it, stop your statin. I mean, we think we have to have our statin every single day. It's not like other medications. You could stop it for a couple of days if you think you're going to go on. It's a terrible side effect with statins and Paxlovid.
Yeah, there's a whole list of meds that
is the biggest one. And so many people are on statins over 65.
Right.
So if you're on a statin and you get it, and now you're day 5, you might not be able to start it because you're statin. So I've been telling people, if you think you're going to get it, if you've been exposed, if you have the sniffles, stop your statins for a couple of days. You can restart them. It's not a medicine that cannot just be started and stopped. It's not going to have a bad side effect for being off it for a couple of days. There's no rebound for being off statins.
Yeah. It won't be out of your system right away, though, if you stop it.
Right. But I'm saying it still is better if you stop it a couple of days before, if you think you're exposed, because it's not like some blood pressure pills. You stop them and then you're going to rebound. You don't rebound anything if you stop a statin for a little bit.
Sure.
Thanks,
the
Myra.
other common thing that people take over the counter, that's a problem, is St. John's wort. And that may not be on a pharmacy list of meds that are contraindicated. So this is why you must go through a provider and let them know there are antihypertensive, there are other things on this list that are contraindications to taking it. So people just need to be mindful and know that it's out there, particularly if you're super high risk.
So Beth Barnett also just posted unvaccinated or under vaccinated are also eligible because they're considered high risk. Yeah, which is kind of interesting.
Yeah.
So, yeah.
Okay, so that's it for now. Happy to answer any other questions that come up at the end of the meeting. I want to make sure that Josephine has plenty of time to share her expertise with us. And so I'll sign off with my mic right now.
Thank you. All right, Dr. Young.
Okay, well, good morning and good afternoon to everybody. I am absolutely delighted to be here today to have this opportunity to talk a little bit about long COVID. And this is very much meant to be a conversation. So please ask questions in the chat at any point, and you can also plan on having some time at the end to maybe have a more interactive dialogue. So what is long COVID? It's actually been called by a whole bunch of names, and long haul COVID, post-acute COVID-19, post-acute COVID syndrome, PACS, for a really long one, post-acute sequelae of SARS-CoV-2 infection, also termed long-term effects of COVID, chronic COVID. And so, for the sake of simplicity for our conversation today, I'm going to stick with long COVID. But I think also this range of names, the reason I even bring it up is that I think that really speaks to the fact that we're still continuing to learn about this entity and trying to understand kind of what's causing it, the long range effects of it. And so, information may change over time. And this is what we have at the moment for now. And it's really defined as a constellation of long-term symptoms that some people experience after they've had COVID-19. So how many people, statistics vary out there, but I would say the general working estimate is that about 30% of those who've had an infection will exhibit some manner of long COVID, which means that of the 85 million cases in the US, there would be at least 25 million or so who've had long COVID to some degree. And typically it's more women than men are affected, more adults than kids. Kids usually will manifest more with insomnia, difficulty concentration, but they seem to resolve faster than adults. Most that have it are middle-aged. And certainly more at risk if individuals already have underlying health conditions prior to getting COVID. And also in line with the sobering statistics that Dale just presented about communities of color, there's a disproportionately higher rate of long COVID within most non-white populations. I don't have the specific numbers to share here today about that, but they certainly go along with higher incidence of severe disease. And I just got a message that my internet connection is unstable, so hopefully it'll hold up. But certainly, goes along in line with most communities of color being disproportionately affected by more severe illnesses with COVID. So what does it look like? I mean, there's been a lot of talk about it in the news, and I think we can probably all quote that, it's most common with general fatigue, worse after exertion with symptoms, and then brain fog. And then depending on how severe the original bout of COVID was, there can also be damage to multiple organ systems, including the heart, lung, kidneys, skin, and brain. For some, it's really kind of manifesting with symptoms similar to chronic fatigue syndrome. And so it's just, people are generally worn out. And the way that I've been thinking about it, that I find it's a little bit easier, is that to think about it in four main categories or four main domains. So think about it from the standpoint of body, mind, mood, and function. And that last one, function, being essentially a result of the degree to which the first three of body, mind, and mood are affected by long COVID. So first we'll talk about body. I mean, these are the physical symptoms. And people can have one or more of these, and often it is a combination of multiple symptoms. They can start with the infection and then just linger on for months or years with similar symptoms. They can come and go. They can change over time, or it could even be pretty mild of an illness to start with, and then these types of symptoms will show up later. Certainly, they're more common with more severe cases of COVID infection initially, but we've certainly seen it in individuals who only had mild infections, or even in ones where there may have been a documented infection that didn't have any symptoms of infection at all. So it's all it can really manifest across this whole range. So if I go kind of by just general systems, like general, it's that tiredness, that fatigue that doesn't really even improve significantly with rest. There may be some ongoing fever, oftentimes low grade, and definitely increase of any types of symptoms with exercise or mental effort. Respiratory symptoms, shortness of breath, cough, chest tightness, those kinds of things. From a cardiovascular standpoint, there can be chest pain, kind of a little bit different than just the general chest tightness, a rapid heart rate, or even a pounding heart rate, that people refer to as palpitations. There can be on a more microscopic level, there can be like leakiness of the blood vessels, so that there can be kidney and liver damage associated with that.
What do you mean by leakiness? What is that? I don't really understand.
So that like the blood vessels themselves are not functioning as well as they might. So there might be more going on in terms of swelling and things like that. And so that the kidneys are not able to function quite as well, and the liver is not able to function quite as well relative to that.
Yeah, scary.
It is. I know. I mean, just even going through this list, it just causes some level of anxiety to even think about it. So from a neurologic standpoint, there are people who are experiencing like chronic headaches, dizziness with standing up, some things called paresthesia. So kind of that pins and needles feeling, how when you're feeling kind of numb, normally that goes away, but some people just have that just sort of there all the time. And certainly, the very familiar loss or change in sense of smell and taste. And what's interesting about that is, I think people have sort of gotten used to hearing about the loss of smell and taste that hopefully eventually comes back. There are those for whom it still doesn't come back, or a lot of people who say it's just not quite the same as it was before. People who really were very sensitive to certain smells or very acute in their, very, very precise with a sense of smell and taste. And now it's way more dulled, or certain things that used to bother them couldn't care less because they don't smell it anymore. So, some of these things can be pretty long lasting. From a GI perspective, some people end up with chronic diarrhea, chronic stomach pains. We hear this other one a fair amount with musculoskeletal standpoint. There's joint aches, muscle pains, kind of that very nondescript achiness, things there all the time. There can be some rashes. There has been some reports of hair loss. And then from an endocrine standpoint, there can also be changes in menstrual cycles. There can be some impact on thyroid function. Thankfully, not everyone gets all of these things, but that's what makes the diagnosis a little confusing too, because you can have bits and pieces of it. It can come and go. And some of it also kind of goes along with things that might happen anyways. And so it's really partly in that diagnosis, it's having that conversation and figuring out what has changed really dramatically from the original baseline before having COVID. And usually, people will have that sense of just, don't feel right or feel very off. So those are things related to body. So if we go to mind, this is more about, symptoms related to how you think, not so much how you feel. And so with the mind things, we usually see an increase in any of these physical symptoms or mental symptoms with mental effort being made. So if you're trying to really focus on working on a task or really doing focused reading or that kind of mental work. So brain fog we hear a lot about. So what is brain fog? I mean, I think we all have a general concept of it. We've probably all felt it from time to time. I think the most equivalent would be like when you're super tired, or maybe when you've had like a bad flu or something where you feel fuzzy, your thinking is just not sharp, and you just can't think as clearly as you'd like. And so in this particular instance, it's just constant. It's just always there. You sleep, you rest, you're not even doing anything that demanding, but it's just that kind of fuzziness that's there. Poor memory. Just having a hard time hanging on to information, and then just trouble paying attention, staying focused, trying to solve problems, concentrating, those kinds of things, which, when you think about the fact that with kids, this manifests more, that has a pretty significant impact on school as well. And then, so that's body and mind. And then moving on to mood, this has more to do with how you're feeling. And this is where we see a lot of reports of people feeling anxiety, depression, and some of it also PTSD. Now with PTSD, with post-traumatic stress disorder, that is more in line with people who had those really severe hospitalizations, especially if there was an ICU stay or prolonged hospitalization or ICU stay, where there is that PTSD just from having had such a significant illness as well. So similar to other severe illnesses that have happened. So not necessarily unique to COVID itself. And then the last part is function. So how does all of this interplay together? The hope is that people, even if they have long COVID, this may just last a relatively short period of time, but sometimes it can go on for, the better part of a year. And now that we've had a couple of years worth of experience with COVID, some people have had it, for the majority of that time. And so when we think about function, think about it in two different areas or levels. I mean, things that you think about all the time anyways. So, activities of independent living versus activities of daily living. So in terms of independent living, can you do fine on your own? The equivalent of just like living by yourself, the executive functioning and planning of things. Can you work? Can you manage your finances? Can you attend school and pay attention and do well? Can you drive? Can you go shop and do your own meal prep? All of that. Versus those activities of daily living, for people who are significantly affected by this, either as a direct consequence of having an initial severe COVID infection, or just even a combination of these other things that have occurred as part of a long COVID. So, self-care in terms of feeding, bathing, dressing, grooming, all of those, like, can you just take care of yourself to meet your basic needs? So I'm going to stop there for a second. Any particular questions just about how it can present across body, mind, mood, and function?
Well, and we do have some questions in the chat about if there's any correlation between long COVID and patients who have taken Paxlovid, sorry. Paxlovid.
Yeah.
Sorry, I'm not reading it very well. And we also have another question about, can you develop long COVID if you've never had a positive test?
So I'll answer the second question because I don't know actually the answer to the first question about Paxlovid. Partly it could be that we don't really have enough data yet. I don't know if Dale has any thoughts on that.
And I think earlier, go ahead, Dale.
Yeah, why don't you fire away with yours, and I've got some material. Let me see if there's anything. I don't think there is, but why don't you answer and I'll look.
Okay, that sounds great. So, in terms of if you've never had a positive test, yes, especially because the accuracy of testing, sometimes people have had like all the symptoms that go along with it, and they were around somebody else, they got exposed at the same time, same symptoms, but they have a negative test. Those individuals, in the course of a workup for long COVID, they are also considered as possible for having long COVID. So certainly if you had a documented test, that helps. But if you didn't, if you had the right clinical history that would go along with it, it is certainly considered as a possibility for long COVID as well. And then also because there are also those who had very, very mild symptoms that it might seem like it was just a cold or something, or even no symptoms at all.
I remember earlier, because we had a conference last fall, and Diana Barrett, who is the founder of Survivor Corps, mentioned something that I thought was really striking, which was that there were higher percentage of cases of long COVID in asymptomatic COVID. Asymptomatic, so no symptoms, were more likely to get long COVID than symptomatic COVID. And I'm just wondering if that's held up over time, or if that's changed, or if we know anything else about that.
Yeah, I mean, I think in most of the reading that I did in putting this presentation together, it really spoke to more about an increased risk with having had a more severe case of COVID, and that it's possible to have it with milder cases or asymptomatic cases. But, that being said, they are also difficult to study, but I would say the majority of the reporting right now is that the more severe the illness, the greater risks. And I think we can see how that can play out as I talk a little bit more about what causes long COVID, or the potential for the causes.
And Dale, did you want to jump in here?
Yeah, let me just add a couple things about the Paxlovid. It has not been widely available in pharmacies until May. So I think we will not know one way or the other. The one thing that's interesting is some of the side effects, they're not allergic reactions, are altered sense of taste. Well, so that's something that we see with COVID. And so it's not clear whether that's the drug itself or whether that was going to happen anyway. Diarrhea, high blood pressure, muscle aches, things like that. And then obvious possible allergic reactions that people could have. So I think as with much of the COVID stuff, we really need way more time to know if there's any kind of association with that or not. My suspicion is that it probably doesn't make a difference one way or the other because it's ameliorating what your body's doing in a response to the disease. And so if there is to be long COVID, it will, it will happen whether you took the Paxlovid or not, from a physiologic way of looking at it. But I think we just need months out to know, especially since we have sort of a nebulous diagnosis of when you get long COVID, the diagnosis, whether you're going to use the World Health Organization or CDC. So I'll turn it back to Josephine to finish out her comments.
And Josephine, we also had an interesting question from Marianne Harding, which is, or Myra Katz, sorry. Do we have any diagnostic tests yet to prove long COVID versus depression or fibromyalgia? So differential diagnosis. We're still early days, even though it's been a couple of years, but right.
Right. Absolutely. I mean, it's been a long couple of years,
Yeah.
But yeah, we are so early in the course of dealing with a new chronic illness. I mean, I keep thinking back to like the very early days of HIV, obviously very, very different disease and modes of transmission and all of that. But you think about all the things that we learned along the way and what the extent of the impact and things we got right, things we got wrong early on. So yeah, we're very, very early in this. So I see a few questions in the chat. What I'm going to do is just talk about this next part and then come back.
And I'll keep track of the other questions.
Yes,
so everybody who's putting questions in the chat, don't worry, we will get to your questions.
Yeah, definitely. Please keep putting them in. So, in terms of what causes long COVID, there's three main possibilities that are being considered. One is just the direct damage from the virus in the body. So depending on where the virus had its major attack, whether it's in the lungs, whether it's in the blood vessels, in the heart, things like that, that's going to show up in terms of what organ systems may be affected and to where the more severe symptoms may be. So that's related to that. And there's some thought that, there may be residual virus that stays in the body or some fragments of it that continue to cause issues. And then there's the other part. Another thought is that, the initial infection really revs up your system. And so your body does everything it can, sends, immune system into full gear to go fight it. So it goes into overdrive and then it kind of overshoots. And so, it not only fights the virus at the time that's needed, it continues to fight as it goes on, and it's just in fight mode. So now it's fighting your own cells and organs. So you flip more into that autoimmune, inflammatory, chronic state, which then—
And are people with autoimmune conditions or those predisposed because they have maybe had that in the past? Are they at more risk, or are they handling COVID differently than the general population?
Yeah, I mean, I think there's definitely ongoing studies looking at that. I mean, if your body is already revved up, then there's the potential for that. Although one kind of tangential piece to that, which is interesting, is that people who have autoimmune diseases who are being treated with medications that make them immunosuppressed, they're in this interesting situation in that because they're on this potentially immunosuppressing medication, they're at greater risk of having, of being infected with COVID. And yet at the same time, they have a level of protection in potentially not having a very severe case to some extent, because their immunosuppressant medication actually stops the body from having as much of that overdrive response.
Oh, that's interesting. Okay, I've never
really
heard it.
Yeah. In a conversation
that way.
with rheumatologists, that's what they sort of talk about. It's like, on the one hand, yes, they're at higher risk for catching the illness, But because some of the treatments used for people who had those very severe cases in the hospital were some of the medications used to treat autoimmune diseases. So I just thought that was an interesting side piece to think about.
Yeah, and I've also heard that that is why those particular people don't test positive, because they're already,
Yep, that too. And then the third possibility is just that, some of the long COVID symptoms are really more associated with the prolonged ICU stay or hospitalization. So some of the brain fog, some of the PTSD, the anxiety, the depression, the fatigue, joint aches, some of those things just come from a prolonged stay and severe illness. So sort of, keeping some of those things in mind, then coming back to, let's see, where are we picking up? Oh, okay. So is there a relationship between symptoms during COVID and symptoms during long COVID? So yes, depending on where the virus had the main effect, it certainly can. So that's where you're going to see those more organ specific things, but also, again, the symptoms, if they were enough to land you in a prolonged hospitalization or ICU, then you're going to see some more of those other associated ones. Do we have any diagnostic tests yet to prove long COVID versus depression or fibromyalgia? No, there are no specific tests that we can take to say you have long COVID. So then the question is, well, why go see a doctor at all if nobody can prove it? And the reason for that is so that people don't get categorized as having long COVID when they actually have something else going on. And that's actually the bigger reason to get checked if you think you might have long COVID, because you might have something else that just happened in the same time frame that does have specific treatments and things like that. And so, a lot of this is timing and history. And so getting the evaluation done really depends on people being able to say, like, this is when I noticed a change, or better yet, it might be friends or family members who have a better read on that. Because when you're living it, it might be harder to even figure out time-wise what's different or what feels different. So it's going to be that combination of input.
And some of those medical symptoms also are kind of nebulous to get diagnosed to begin with. So that's why advocacy is so important, right?
So, absolutely. Yeah. I couldn't agree with you more, because I think, when you have this range of nebulous stuff, and then when you're also feeling like you're not thinking clearly, and then you have potentially, medical professionals who are doubting what you're saying or trying to easily attribute it to something else, I think having that advocacy then is needed almost more than ever, because it is having that validating conversation to be able to ground yourself and being able to focus on, okay, these are the things that are different. I know this, versus saying, gosh, I just feel tired. I can never catch up. Oh, well, you just need to sleep more. Oh, well, you're busy with work, or you're busy with kids. Of course you're tired. And that's not it. I mean, as we all know, when patients are really having that conversation, they need to be heard.
So Myra was asking an interesting question, which is, are we seeing more symptoms in women than men? I think you touched on part of that previously. Mm-hmm. Yeah.
And so, when they've looked at the studies, and there's always there's the study and the results, and then there's the, but why, is it really that difference? Is it that women are maybe more attuned to what they're feeling? Is it that women are maybe more willing to raise the questions about, hey, these things feel different, or I'm not functioning as well as I would like, those kinds of things. But it's certainly study after study, we're seeing a higher proportion of women presenting for care, presenting with the symptoms on self-reported surveys, things like that. So it could be that there is some biological connection there, but that, thus far in these 2 years, that's what we've seen.
We also got a question from Marcy Barnes. Are current variants causing long COVID at the same rate as early variants?
Oh, interesting. That's a great question. I've
Yeah.
not seen any studies that separate that out, but also if you think about how long it takes for studies to come out to make sure that the results are valid and they've collected the data and all that, we're not that far out from the most recent variants. Thinking specifically of Delta and Omicron, and then all the subvariants of Omicron makes it harder as well. So I don't really know. I do want to go back to Marianne's question of, are vaccinated people less likely to develop long COVID after getting COVID, especially Omicron? So I don't know about especially Omicron, but in general, people who are vaccinated have certainly decreased their likelihood of developing COVID. The current estimates that people are working with is it looks like it's about 50%. Some studies have reported as high as 70%. Other studies have reported, closer to 15 or 20%. But regardless of what percentage, it's just knowing that it does offer a level of protection. And so, I think as we've started to see less severity in hospitalizations and less death associated with, big bumps and surges in infection numbers, I think people are starting to think more about long COVID, and that's sort of almost a scarier thing to deal with. Like, what does it mean? Yes, chances are good that I won't have long COVID if I do have COVID, but 30% is very real, especially for some of these things that can go on for some period of time. And I also, and I'll just finish this thought, that there's also the conversation around vaccines, for people who are hesitant to get the vaccine, like, well, the vaccine hasn't been out for very long. We don't know enough about it. I don't know what the vaccine is going to cause. I would say that, while all of those questions are important to consider, I would also put on the table at the same time that we also don't know a lot about this virus and what it can do. And so it's sort of, weighing one versus the other, and what's the likelihood of getting infected to start with.
I'm curious, similar to other diseases that are staged and graded, I'm wondering if long COVID, once we have more information about it, will be graded in terms of patterns among certain types of long COVID, because it seems like the symptoms are wide ranging and definitely vary in severity. So I'm really curious about that.
Yeah. I think there will at some point need to be a maybe better ways to categorize the type of long COVID that's there. And it's interesting, because there's guidance that's put out about when long COVID would be considered within the ADA
disability.
Yeah. And already, having the conversations around, it's really how many areas of function does it impact? And it could be in the end that's the path that goes down, rather than maybe even necessarily the physical manifestation of it, because that's only one piece. And ultimately, it is the functional impact that's going to make the biggest difference.
Right. Yeah. And I think this is a great conversation to have, because there will be people that probably have mild long COVID that aren't reporting symptoms just because they're not even thinking they're related. And in the whole picture of life, it probably doesn't matter. So it's really I think the ones that have significant long-term complications are the ones that we're going to want to focus on from a healthcare perspective, and making sure that they get to people who know how to best manage that, whatever their composite is, or their specific, if it's cardiac or if it's pulmonary, whatever their specific major impact is, that's attributable to that. And really and truly, it comes down to that they're getting the care they need, and that it's being covered by whatever their insurance is.
Right.
The only other thing that I would wonder about is if long COVID, like having an autoimmune condition kind of in the background, puts you at greater risk overall for kind of turning on different things over your your lifetime after you develop that. Because having some experience of this myself, and even if you're feeling great and in remission, you have that in the background, which means that often a lot of things that are no big deal, can be very triggering and really tank your health in a very big way.
Right. Yeah. And if you think about it, you could have two people coming into something, and one has a really severe case and the other one doesn't. And otherwise they were fairly similar. And if you think about how part of how we respond to illness is just our makeup in general. And so if your system tends to go into overdrive with things, then if it can, do it in one area, then it could certainly do it in another. And again, I think part of what's so hard about getting these definitive answers to some of these things that intuitively seems to make sense is that it's just hard to study, and it's hard to find everybody and to study them for a long enough period of time and to have people to compare them to. So it's so I think that's what's going to make this part of the time challenging. And there's lots of data being gathered into databases. And so I'm sure we'll know so much more in 5 years than we know right now. But I think it is important to be raising these questions now, because those are all things to be thinking about.
So Dr. Young, do we know yet in terms of for people who develop long COVID, and what if they're getting like into a specific long COVID doctor and rehabilitation situation, which I know those places are pretty rare. But do we know kind of how people are doing better, or what kind of, how they can be doing better, and as advocates and people who are very engaged in advocating for patients? Are there things that we should know about in terms of making sure that long COVID patients are kind of steered towards either doctors or rehab facilities, or certain questions?
Yeah, for sure. So, I would say that even though there's no specific test, kind of going back to, then what's the point in going to see somebody? It is as much to rule out anything else that is treatable, that is otherwise known, that just happened to occur around this same time. And definitely, if you're in an area where you can get to a long COVID clinic, it would be well worthwhile. And the nice part is that a lot of these long COVID clinics are set up to be able to see patients virtually. So you don't necessarily have to be geographically in the same area. And I think based on the last map that I looked at, I think there's only 2 states in the US that does not have a long COVID clinic somewhere. And what's nice is that, most of these clinics are set up, in a multidisciplinary way. So it's going to be some combination of specialists with in pulmonary, lung medicine, cardiology, infectious disease, rheumatology, and immunology. Now, not all clinics will have all of them. Obviously, the ones based at the larger academic medical centers will have more of that. But what's really nice is that for once, you're not a single patient running around to multiple places. All the specialists come to one place for you, and they can really look at you in light of all of those things, so that if there's actually a piece in the history that separates you out from kind of the typical long COVID, then there may be something very specific to address. So they're evaluating for other treatable causes. Also, in working with the long haul or the long COVID clinics, you have the opportunity to get connected with the latest information. And as research is going on, if there's research studies to participate in, or even being part of a database, you're going to be a little closer to that newest, latest information coming out that's more directly applicable to you than just sort of waiting for a news story to come out, or a press release, or whatever somebody may be putting out there on the internet. Getting some support from others with similar conditions. But in terms of being seen in the clinic, what can they actually do for you? Still a lot of the treatment is very supportive, and the focus is really on increasing quality of life. And so rather than necessarily treating the very specific long COVID in of itself. It's like, what are the areas where it's really impacting your function on a day-to-day basis? And so what can be done to improve those things? And of course, there's all the perennial advice, right? You get rest as needed. And even though if you don't feel necessarily a whole lot refreshed from getting rest with long COVID fatigue, it's still important to get rest as needed. And then, regular sleep at night, knowing that people are battling insomnia as well, a healthy diet, staying well hydrated, physical exercise is tolerated. And it's always that tough balance. I mean, same thing for people with autoimmune disease. You feel crummy, you're tired, you're achy all over, and yet moving is what will make you feel a little bit better if you can kind of overcome that initial piece, spending some time outdoors. Looking at activities for mental stimulation through preferred activities, that engagement is helpful. The social engagement, and interaction as able. And then also there are some clinics that are more focused, and some of this is happening more in Europe, where they're focused on occupational therapy and physical therapy, both to kind of increase strength, but also increase autonomy and independence. Because part of it is, if there's the potential that this is going to go on for some period of time, being able to start to almost help to support that change in mindset of, okay, not so much what can't I do now, but what can I do? And then building that out as strongly as possible.
We do have some questions about testing here.
So
one is, if patients are having long COVID, will they still test positive for COVID during the time that they have that?
They shouldn't, because, in order to test positive, you're talking about having a certain amount of viral load to show up on the rapid antigen test. I mean, you can show up positive with a smaller viral load with PCR testing, but long COVID isn't necessarily caused by this ongoing infection. It is sort of, the damage done initially and the body's reaction or overreaction to that damage.
And
so if they test positive, they may have gotten it again.
Gotcha. And Sandy Johansson wants to know, are all who test positive considered to be contagious for as long as they continue to test positive? I know there's a lot of controversy over this question. Yeah. So good question.
Right. Yeah. I would say in general, and I'm happy to have Dale weigh in on this too, it depends on the kind of test. So testing positive on a rapid antigen test, you're probably much more likely to be contagious because you need a higher viral load to test positive on that. If you're testing positive on a PCR, because it doesn't require as much virus, you might not necessarily be contagious. So it sort of depends on how far out you're testing from your initial set of symptoms. And also, especially if you're not really having much in the way of kind of that acute COVID symptom, and then the chances of you having a significant enough load to then transmit enough to get somebody else sick is much different.
Yeah, it's a challenge in healthcare because if you are asymptomatic, we're really relying on you having a negative antigen test or PCR, but mostly we're going by follow-up antigen testing before you come back to work, because we don't know for sure that X number of days out you're not infective. It really depends on where you work and if you're around other people that you could get sick, including your own family and so on. So the days of quarantine and isolation and things like that the CDC recommends may be enough, may not be, depending on the individual person. And just like with how long does the initial infection last, we know that some people, it takes a long time for their body to clear that. And so I think you're not going to have definitive information. Depending on the area you work in, those guidelines will need to be there for safety of others and may or may not represent infectivity or your ability to get someone else sick.
Yeah, thank you. We also have that's great, really good discussion today. It's great to be back and learning all this good stuff. So So Beth Barnett asks, long COVID affects so many body systems, and she wonders which specialty or NIH institute is leading the research on long COVID, and what specialty leads a long COVID clinic, if there is one.
Yeah, I would
good
say
question.
that, yeah, it's a great question. I think initially this really, as I looked at how different clinics popped up in different places, I think it really had to do with, who had the most interest, and in terms of, which specialty ended up leading the conversation. And I think by its nature, because so many people had pulmonary or lung issues, pulmonology has been core to the conversation, as well as because of the increased blood clot risks and the impact on the heart. Usually it's been pulmonary and cardiology working very closely hand in hand, but like right behind it, you've got the rheumatologist, the immunologist. And so again, you'll have the richer conversations in those academic medical centers that are well staffed in all of those specialties. And so who's leading it depends on who has the resources and the staffing to do it. And an NIH level, I'm actually not sure. I don't know, Dale, if you're familiar.
No, I'm not, but there are pockets, for instance, at Swedish, our lead researcher is an infectious disease doc. So
Right.
So you'll find that where it's exactly right, Josephine, is where someone has an interest, a drive to try to figure some of this out. And we'll see pockets of research, I think, that will be meaningful no matter where it came from. So if it's pulmonary, obviously the people that got hit the hardest there are potentially going to gain from that. And our overall knowledge will come from all of that. There's a little bit of research on COVID in pregnancy. It's more based on incidence, and now we're looking at potential impact on the placenta and risk of stillbirth, and we don't know enough about that yet, but there is an association that looks specific. It's probably a small risk, fortunately, but looks very specific placental changes. So that's going to be pathology looking at that. So I think you're going to start seeing more and more information coming out from a variety of specialties that that are taking interest, thankfully, because it's a very complicated viral illness. Yeah.
So Dr. Young, one last question. I know that we're going to be wrapping up in a few minutes. So if anybody has any final questions, please put them in the chat. But your background being a pediatrician, I'm wondering what percentage of kids that get COVID go on to get long COVID, and is there enough information to even understand what that looks like?
Yeah, generally there's not enough information. There's not enough studies out there. It's always hard to study kids because people don't necessarily want their kids to be studied. So all we know that the numbers are a lot less than in adults, and that it tends to last for a much shorter period of time. So there were some studies that looked at for adults, like if you still had symptoms 15 weeks out, then you might have a greater chance of the symptoms going on for a year. Versus kids who are manifesting with symptoms, they might resolve within a few months. And so, I think there's some hope there, but it's so hard because you're also layering this on top of a baseline pediatric, especially because it manifests in behavioral health changes. That coming into COVID, we already had about 20% or 1 in 5 kids having some manner of behavioral health condition going on, anxiety, depression, and other things. And in some age groups, especially amongst teenagers, there was kind of a 30% bump in behavioral health issues as well. So now all of a sudden you're in some groups, you're pushing closer to 1 in 4. And then to try to separate that out from, is this long COVID or is this just, life in general and all of that, it just gets trickier to go. But I'm at least hopeful. Sorry. First appearance you made. I'm at least hopeful that it'll continue to be on the lower side, because goodness, kids do not need anything else to get in their way. This has been a rough 2 years, especially for them.
Yeah, indeed. Well, with that, I just want to thank you, Dr. Josephine Young and Dr. Dale Reisner and everybody who has shown up today for this great discussion on long COVID. There are a few resources that were put in the chat, and I'll be working with Sophie to try to also send that out in our follow-up email that you should get shortly with a copy of the recording in case you want to pass it along to anyone. And I wanted to remind people that next month in July, we'll be having our next community conversation July 11th. And the topic will be to be announced, I believe. And then we will to be announced. So stay tuned. And also we will be having a case review, which is a free benefit of membership on July 14. So make sure to check your calendar. I believe that's at 4 p.m. Pacific and 7 p.m. Eastern time on July 14th. So with that, just thanks so much, everybody. Great to see you all, and we'll see you next month.
Thank you so much.
Bye, everyone.
Bye.
Josephine.
Bye.